9 o'clock. Today all my sessions are overlapping. That's why I had to disturb you people. I'm very sorry, Kalpana, Arun.
No problem, sir. It's a pleasure to have you here, sir.
Before he connects, I'll talk anyway. I'll go on talking. I don't know when he will connect. I'm supposed to talk about vertical strabismus. Now, when the question of vertical strabismus comes, what is vertical strabismus? Is problem with the vertical muscles, a vertical strabismus, or problems due to oblique muscles is vertical strabismus. There are a lot of confusion in the minds of the people. DVD, they say, is a vertical strabismus. DVD is not a strabismus. Vertical strabismus करके PowerPoint है, वो देखना. He couldn't connect there was a video and photograph in my phone, he couldn't connect it. So I was sitting there instead of sitting that side. You managed very well, Arun.
Thank you, sir.
Now the question arises, a problem with the superior rectus can lead to a vertical strabismus. Yes, a problem with inferior rectus can lead to a vertical asymmetry. But what about a problem with an oblique muscle? Also can, in smaller amounts, give rise to vertical strabismus. When the oblique muscles have larger problem, they give rise to torsional strabismus. So therefore, when you say management of vertical strabismus, it's important to recognize which muscle is involved. Is it superior rectus or inferior oblique? When the eye is hypertrophic, whether it is inferior rectus or superior oblique in the opposite eye. Where the eye is hyper, it could be a problem due to inferior oblique and superior rectus in the ipsilateral eye, or it could be due to a problem of superior oblique and inferior rectus in the opposite eye. So you have to decide which is the problem. What helps you decide clinically is the cover test. Okay? Hypertrophic eye, if it is due to superior rectus overaction, okay, all the superior muscles are intorters, all the inferior muscles are extorters. If you remember, that is very easy to distinguish. If it is due to a superior rectus paresis, the eye will be extorted. If it is due to superior rectus overaction, which can happen in some cases, the eye will be intorted. Okay? If it is due to inferior oblique overaction, the eye can be up, but eye will be extorted. Now, how do you differentiate inferior oblique overaction from superior rectus? Very simple. Look at the disc and fovea. If the fovea and disc are not in the same line, that means there is a torsional element. If the fovea is below, okay, if there is extorsion like this, supposing this is the fovea, there is extorsion, fovea goes down. So if the fovea is below the line from the middle of the optic disc to the fovea, if it is below the line, that means there is extorsion of that eye. You get it? It's very simple. Take the ophthalmoscope or take a streak retinoscope, and through the streak retinoscope, look at the disc. You can look at the disc through the streak retinoscope. Has anybody tried that? No? Okay, try next time. Now, when you look at the disc, keep the streak horizontal. If the disc and fovea are not on the same line, that means there is extortion. If the middle of the disc and fovea is not in the same line of the streak, that means there is torsional problem. If it is above, it is in torsion. If it is below, extorsion. Very simple technique. You don't need lot of equipment. But, however, when you want to deal as he hasn't started the time. Doesn't matter. Leave it. I'll talk just like that. I'll make them understand. Don't worry. Start the time. I have only 4 more minutes to go. Now, what is important is there are many conditions affecting inferior oblique, superior oblique, inferior rectus, superior rectus. So how does a general ophthalmologist go about dealing with this and decide which muscle to tackle, which muscle to not tackle? Because inferior oblique muscle is like mother, very forgiving. Superior oblique muscle is like your girlfriend, very troublesome. And you handle the superior oblique improperly, it will curse you for the lifetime. So be very careful. Inferior oblique muscle is very nice muscle, very gentle, soft, like mother. You can cut it, burn it, it doesn't trouble anybody. Okay? So as a general practitioner, general ophthalmic practitioner, you have every courage to touch inferior oblique if you feel that it is inferior oblique. I'll give you one small example. Some fellow after my talk went and said you can cut the muscle and all. There was a vertical squint. He said, this must be due to problem with inferior oblique. Possible his diagnosis is correct, but he cut off the inferior rectus. Then he sent the patient, sir, you said you can cut the muscle. I said, yes. But I cut the muscle and the eye is hypertropic even more than what it was before. He had cut off the inferior rectus. So fortunately, there was no problem. He sent the patient. I found the inferior rectus because if you don't tackle the other attachment of the inferior rectus to the oblique, it stays there. So I brought it forwards and resected it. So when you listen to my talk, please listen a bit more carefully. If I say cut the muscle, nothing happens. Yes, inferior oblique you can cut it, nothing happens, but not inferior rectus. Okay. So don't remember parts of my talk and blame me. Santhan Gopal said cut the inferior rectus. Was it the rectus or oblique? He gets confused. No, some muscle he said cut it off. I said, I cut it off and I began. So therefore, while operating, you must be very careful in deciding which muscle to operate as far as vertical muscle is concerned. Second, since there are many causes for inferior obliques, inferior rectus, superior oblique muscle problems, then you cannot decide just clinically which muscle to operate. You may need force reduction test, you may need MRI also, you may need dynamic MRI in some cases. Okay, these are all the investigations which you have to complete because your diagnosis if it's superior oblique, if it is congenital or acquired depends. If it is for example, the monocular elevation deficiency which is acquired, that's what I wanted to show, then you need to do MRI to see where is the problem. Here a patient came with monocular elevation deficiency, acquired monocular elevation deficiency, which probably just a superior rectus, whereas is a hypertensive patient, so I had to do MRI to find out where is the problem. So like that, if any vertical squint, the things you have to keep in mind is you must decide which of the 8 muscles, to confuse you even more, God has given 2 inferior obliques, 2 superior obliques, then 2 inferior recti and 2 superior recti. He totally confuses you. But there is a reason why he has given 8 muscles for vertical movements. So you have to decide which muscle to operate, which muscle to tackle, what to do, and when to do and how to do. These 5 things. Now, when you tackle a vertical or an oblique muscle, you must be 100% sure which muscle you are tackling, except when you can't tackle inferior oblique. Even if you make mistake, nothing happens. Generally, please remember, don't tackle inferior oblique for some other muscle, but generally nothing happens. But all other muscles, as a general ophthalmologist, be careful. You must get MRI done. Depending on where is the cause, you must get a force reduction test. And remember, DVD is not a squint. Okay, I'll stop at that. Thank you very much. Sorry for all the confusion. It never worked.